acids, water, and other substances that are essential for the body metabolize and reabsorb. Urine contains waste products and excessive water out of the body. It excretes excess water out of the body. 95% normally urine contain water and 5% solutes. So it should be analyzed as soon as possible. Ideally, after passing the urine which is collected in the bottle, that should be sterile bottle, within 30 minutes of collection it should be given to the lab. If not possible, you can't reach to the lab is away from you, it should be refrigerated for not more than 6 to 12 hours after the collection of the sample. Okay, so refrigerated urine should be brought to the room temperature and thoroughly mixed before analysis, and urine should not be frozen if we want to see the sediment analysis. So various types of the urine samples. One is the random sample. Random means at any time, morning, afternoon, evening or night, at any time you can pass the urine and do the test, that is called routine screening. Morning sample, first urine in the morning, that is usually most concentrated urine. It should be done for the pregnancy test or sometime microalbuminuria and microscopic examination. Clean catch midstream urine. In this sample, we should discard first few ml of the urine and then collect the rest of the urine, and it should be sent for the urine culture and sensitivity. 24-hour urine collection is done to see the qualitative and quantitative analysis of the different substances in the urine. The method of this sample, how to collect the 24-hour urine. In the morning, first discard the urine sample. After that, you have to collect whole day, whole night, and on the second day early first sample. Then it should be sent to the lab. Postprandial, 2 hours after meal, that is done to see the glycosuria in case of the diabetes. Suprapubic aspiration, it is usually sterile urine. So urine analysis is divided into the physical examination, biochemical examination, microscopic examination. And physically, we have to see the volume, color, odor, reaction, pH, specific gravity. In biochemical examination, we have to see the proteinuria, glucosuria, ketone bodies, bile salt, bile pigment or hematuria. In the microscopic examination, we have to check the RBC, WBC means cells, crystals, cast. Where there are various casts in the other slides. I want to teach you in the detail the microorganism, parasites, and the contamination. So now volume of the urine. Normally, normal person should be pass the urine between 800 to 2.5 liter or 2500 ml per day. There are some terminology which is important in certain disease. One is anuria. Anuria, when patient pass urine less than 100 ml per day. Oliguria, more than 400 per ml per day. And polyuria, more than 3000 ml per day. Then odor, aromatic normal, foul ammonia like bacterial decomposition, UTI, fruity sweet, ketone bodies, maple syrup urine disease, and mousy phenylketonuria. It is the amino acid disorders. So there are the different odors by which we can detect the various diseases. Then color is important. So colorless to black, normal colorless to yellow, or dark yellow concentrated. If you see this bottle, the demarcation from the bottom is the cola color urine. Rhabdomyolysis, when there is a breakdown of muscle takes place, so or after heavy exercise or crush injury. Then blue green contrast medium, after contrast medium or certain drugs it can occur, or familial hypercalcemia. Red blood cells, infection, stone in which red color urine occur, and brown in case of bilirubin, brown pigments can occur. Extracolor normal, dilute when there is overhydration or diabetes insipidus or patient taking the diuretics. Clarity of the urine should be clear, no visible particulates. It should be transparent, freshly voided, hazy, few particulates present in case of dehydration, cloudy in case of the bacterial growth, turbid RBC or WBC, milky in case of pyuria, fat or chyluria. So on the left side there is the milky urine tube, turbid, cloudy, hazy and clear. Specific gravity is important due to underhydration or overhydration. We should know what is specific gravity. It is defined as a density of solution compared to the density of similar volume of distilled water as a similar temperature. Normally it ranges from 1.005 to 1.030 depending on the patient's amount of hydration, either patient dehydrated or euvolemic or volume overload. Isosthenic urine in which specific gravity is fixed 1.010 in case of renal failure. Hypoastenuria, it should be less than 1.010 in case of dilute urine, and hyperastenuria, when there is concentrated urine, it should be more than 1.010. These are the various tools by which we can assess the specific gravity of the urine. After that, reaction or pH is very important because it shows the acid-base disorder of the either metabolic or respiratory. Normal pH optimal is 7.5 range. So if pH is below 6, it is very acidic. So patient should modify the dietary habits like protein diets. And pH, if it is alkaline, because pH is important, because in case of acidic pH, certain stones are formed like uric acid, cysteine or xanthine. But in case alkaline pH, calcium oxalate, calcium phosphate, triple phosphate stones may form. Now the term proteinuria means presence of protein in the urine, that is called proteinuria. The method by which we can assess is the qualitative test and quantitative test. In case of qualitative test, we should use a reagent test strip. Quantitative tests depend on volume and time of the urine. Protein concentration in the urine may vary with time and volume, and spot urinary protein and creatinine ratio should be done to see how much protein is losses. If you see the graph on the left side, the grade, turbidity and the range of the proteinuria, negative, less than 6, trace between 6 to 30, plus 1, 30 to 100, plus 2, 100 to 200. So as the degree increases, the proteinuria increases. After proteinuria, then another substance which can appear in the urine, that is called glucose, glycosuria. A kidney has got renal threshold for glucose approximately 160 to 180 milligram per deciliter. When the glucose level increase from this above 180, above this threshold, then it can appear in the urine. So clinical significance of this, there are various diseases, tubular diseases or Fanconi syndrome or reabsorption defect or hyperglycemia in which glucose appears in the urine. On the left side, there are various strips but which we can assess the degree of the glucose in the urine. After that, ketonuria. Ketone blood levels are normally very low, 2 to 4 milligram per deciliter. Presence of ketone in the urine. There are different types of the ketones. Beta hydroxybutyric acid 78% and 20% acetoacetic acid, 2% acetone. The clinical significance of the ketonuria is ketone bodies can present in case of dehydration, severe dehydration, or in case of diabetic ketoacidosis or hyperosmolar non-ketotic diabetic coma. Then blood in urine, that is called hematuria, presence of the blood in the urine. Presence of more than 5 RBC per high power field. Urine appear cloudy or red. There are two types of hematuria. One is microscopic, other is macroscopic. Microscopic, that is not visible in the urine, we can see by microscopy, but macroscopic or naked or gross hematuria, it is visible as the urine turns red. Hemoglobinuria, presence of blood pigment in the urine without RBC. And myoglobinuria, presence of the myoglobin in the urine due to crush injuries, road traffic accidents, in case of rhabdomyolysis. Bilirubin and urobilinogen, these are also pigments or which are present in the certain liver diseases or bile duct obstruction, liver damage or hemolytic disease. In case of bile duct obstruction, urine bilirubin triple positive and urine urobilinogen normal, but in case of liver damage, it may or may not be present urine bilirubin, but urobilinogen should be present. Hemolytic disease, again urobilinogen should be present. Now, sometime if you read the report of the urine DR, there is written some nitrite or urine leukocyte estrase. So nitrite basically it is nitrites are the byproducts of the nitrogen waste. The bacteria responsible for infection feed on this waste, breaking it down into nitrate which can appear in the urine. Nitrite test detect the product of nitrate reductase. Basically it is enzyme which is produced by many bacterial species in case of UTI. And positive result on the nitrite is highly specific for UTI. If nitrite is present in the urine DR report, so must think that this patient is suffering from the UTI, urinary tract infection. Urine leukocyte estrase is enzyme released when WBC undergo lysis destruction. So in case of pyuria or UTI, this urine leukocyte estrase positive. So if you read the urine analysis report, nitrite and urine leukocyte estrase is positive, you must do urine culture and sensitivity because this patient is suffering from UTI. After that microscopic analysis of the urine, we have to see the cells, different type of the cells, RBC, WBC, epithelial cast, bacteria, yeast, crystals, various types of crystals, uric acid crystals, cholesterol crystals, due to drugs, calcium oxalate crystals, cast. Basically these are the precipitation of the proteins. These are the cylindrical like shaped bodies, and there are different type of the cast. Hyaline cast normally may occur, waxy cast in case of the renal failure or nephrotic syndrome. RBC cast which are present, and this is our random blood sugar, no? RBC, ACE is mistake. So RBC cast which are present in the glomerular diseases like glomerulonephritis, WBC cast which are present in the pyelonephritis, epithelial normal shading, pigment cast in case of pigment nephropathy. So this picture shows the different type of the cast: urothelial cells, cells from the superficial layer, squamous cells. These are the lipids or waxy cast, hyaline cast, red blood cell cast, pigment cast, crystals. So this picture shows the various type of the crystals, parasites. So we should sum up the urine analysis report. Urine analysis volume, a lady told you 600 to 2 liters, specific gravity 1.003 to 1.03, osmolality 300 to 900 milliosmol per kg, pH 4.6 to 8. So this is table shows the normal value of the urine. So coming to the next part of the lecture, after completing the urine analysis, how to approach to proteinuria and hematuria. First, proteinuria. Proteinuria is defined as excretion of the protein in the urine more than 150 mg per day. So according to quantity, it is divided into the microalbuminuria 30 to 300 mg per deciliter in 24 hours, mild proteinuria less than 500 mg in 24 hours, moderate 500 to 2000 mg, and severe proteinuria more than 2000. According to site, glomerular tubular overflow, primary or secondary glomerulopathy, tubular interstitial disease, monoclonal gammopathies, hematuria, blood in the urine, presence of the blood in the urine. Already told you, microscopic or macroscopic. If it is more than RBC 5, so it is microscopic. Macroscopic, it is gross hematuria. Persistent hematuria more than 2 to 3 weeks or 2 to 3 samples. Glomerular hematuria can occur and non-glomerular hematuria. So when any patients of hematuria comes to you, first you have to ask the age, because age has got important role to diagnose the diseases. Like if any young boy comes to you with the age of 5 to 12 year and he has got history of sore throats, must think that he is suffering from post-streptococcal GN. Sex has got important. Female, systemic lupus erythematosus, common in female. Male, Alport syndrome, that is the genetic disease. After that, color of urine is important. Amount of urine, how much you are passing the urine. Onset of hematuria, clots in the urine, frequency, frothing. Timing is also important, by which we can differentiate either it is the urethral hematuria or the bladder. If the patient is passing the initial stream blood, it is the urethral. If it is terminal, it suggests it is the bladder in origin. If associated symptom, fever, UTI or puffiness of the face, nephrotic or nephritic syndrome. We have to check the blood pressure in case of glomerulonephritis, stone, painless or glomerular hematuria. If the kidneys are palpable in case of hydronephrosis or autosomal dominant polycystic kidney. We have to ask history of the joint pain, SLE, SSP, and nocturnal purpura. So jaundice, rash are important. So history is very important. Drugs, after taking some drugs, family history of renal diseases. Then we have to examine the patient. First, blood pressure is very important. Temperature, edema, ankle edema, anemia, paleness, JVP is important sometimes, heart failure or volume low. Abdominal examination, we have to check the mass, tenderness, or kidneys are palpable or not, skin lesions and joint tenderness. After that, investigations are done to find out the cause of the proteinuria or hematuria, CPC. Sometimes patient's hemoglobin low. If the element of infection, TLC should be raised. If any patient has got low platelet count, he or she can present with hematuria. Peripheral film is very important, that suggests of hemolytic anemia. Serum albumin to see the presence of the protein in the serum. Renal function tests like urea, creatinine, electrolyte, urine analysis, already taught to you. So 24 urinary protein, urine calcium. In case of the metabolic study of the urine to see which type of stone, autoimmune profile, ANA, DNA. Patient of hematuria comes to you, X-ray KUB, ultrasound KUB is important. Sometimes CT KUB. If there is cause of hematuria is renal in origin, glomerular cause, nephrotic syndrome, so renal biopsy should be done. The patient is suffering from multiple myeloma, serum protein electrophoresis should be done. HbA1c, diabetic, and eye examination, fundus examination is very important, because diabetic nephropathy and retinopathy has got association. complement level C3 and C4 level is important. Hypocomplementemia may occur in case of GN. So this table shows the common causes of the proteinuria that has been already discussed to you. So I do not want to repeat this slide, already discussed to you. And these are the common causes of hematuria, already told to you. Glomerular disease and congenital hereditary diseases, primary glomerulonephritis like FSGS, IgA nephropathy, MPGN, post-infectious, secondary glomerulonephritis, HUS, SLE, vasculitis, renal causes. So there are so many causes, surgical causes of hematuria like BPH, bladder cancer, cystitis, stones. So after that, management is very important. Management depend upon the cause of the proteinuria or hematuria. First of all, counseling is very important. We should counsel to the patient and his or her family regarding the course of the disease and manage according to cause, support treatment. If the patient is suffering from blood pressure, antihypertensive treatment should be given, especially ACE inhibitors, salt restriction, fluid restrictions. UTI, antibiotics should be given according to culture and sensitivity. Antiproteinuric drugs like ACE inhibitors and ARBs, correction of electrolytes. If the patient is suffering from stone, we should ask plenty of water. He or she should take at least 2.5 to 3 liter water in 24 hours. And treatment of the systemic disease. The patient is suffering from the GN, glomerulonephritis, nephrotic syndrome, or systemic vasculitis. Treat according to cause. Do the renal biopsy. After that, certain immunosuppressive drugs should be given like corticosteroids, azathioprine, and this cyclosporin, cyclophosphamide. So various immunosuppressive drugs are given according to the cause of the disease. If the patient, unfortunately, he or she develop ESRD and is a renal disease, then there is no option except dialysis or renal transplantation. If the patient comes to you with severe flank pain and hematuria, so must think he or she is suffering from the renal vein thrombosis. First do the Doppler, diagnose, then anticoagulant therapy should be given. Sometimes surgical intervention, thrombectomy should be done. Surgical cause should be corrected. If the patient has got a stone or other obstruction, it should be treated.